Assalamu alaikum. I'm Dr. Ahmed Lutfi. I'm a senior consultant obstetrician and gynecologist. I've been practicing in UK, New Zealand, and Middle East. My qualifications are MBCHP, master's degree, and MRCOG. This is a presentation about management of ectopic pregnancy. Ectopic pregnancy is an implantation of a fertilized ovum outside the uterine cavity, most commonly in the fallopian tube. It is a life-threatening condition. Symptoms would be amenorrhea, lower abdominal pain, fainting or sudden collapse if it is ruptured, irregular vaginal bleeding, usually in a small quantity. Clinical signs of ruptured ectopic pregnancy: pallor of mucous membranes and conjunctiva, sweating, cold extremities, rapid pulse, low blood pressure, tender distended lower abdomen, closed cervix and cervical excitation pain, tender adnexal swelling. Examination of this patient should be very gentle. This is signs of shock due to ruptured ectopic with hemoperitoneum. Initial management at the basic care center. If we suspect ectopic pregnancy, we should refer immediately. We should insert IV line and take blood for hemoglobin and grouping and cross-match. We start IV fluids, normal saline and Ringer's lactate. We document vital signs and refer the patient after communication with the critical care center. Diagnostic tools at critical care center should be serum and urine PTHCG, transvaginal ultrasound, paracentesis and cholecentesis could be helpful if there is no transvaginal ultrasound, diagnostic laparoscopy, and exploratory laparotomy facilities should be available. Management principles: surgical emergency should be treated in the critical care facility, and ectopic pregnancy is a surgical emergency case. We do not delay surgery if patient is unstable. Time from diagnosis to surgery should be 30 minutes. Patient should be stabilized, and blood transfusion if it is needed. This before and after and during surgery. As I said, surgery should not be delayed, as stopping the bleeding with salpingectomy if the ectopic pregnancy is ruptured is a life-saving procedure. Intraoperative management: we identify the ectopic site and control the bleeding, usually by salpingectomy. We assess the contralateral tube, ovaries, and uterus, as this should be documented. Blood transfusion or autotransfusion if needed. Surgical details should be documented. Post-operative care: we inform patient about the findings and the implications. We offer contraceptive counseling and treat anemia with iron tablets. Up-to-date guidelines: expectant management could be possible if patient is stable, being free, and PTHCG less than 1,500 international unit per liter and falling. Medical management with methotrexate injection, single dose, is indicated if PTHCG less than 3,000 international unit per liter, no fetal heartbeat, and the mass is less than 3 centimeters. Surgical management is indicated if patient is unstable with ruptured ectopic pregnancy with hemoperitoneum, or PTHCG is more than 5,000 international unit per liter, or other modalities of management is failed. Summary: early recognition is critical. Stabilize and refer promptly. Use appropriate diagnostic tools. Surgical intervention is often required. Follow-up and counseling are essential. Thank you. This is the end of the presentation.